Good afternoon, and thank you for joining us for today's webinar, Clinical Insights, COVID-19 and the Liver. My name is Ray Chung, and I'm pleased to be co-moderating today's webinar. Today's webinar is being recorded and will be made available on the AASLD website and in Liver Learning. You're encouraged to submit questions directly to our presenters throughout today's presentation using the Q&A box at the top of your screen. We've also made available a separate chat feature. The purpose of the chat feature is for attendees to interact with one another. As a reminder, we will not be taking any verbal questions during today's webinar, so we strongly encourage you to use the Q&A box. We'll answer as many questions submitted to that box as time permits after the formal presentation. I'm pleased to be a co-moderator of this session with Dr. Raj Reddy, and joined by our presenters, Dr. Oren Fix and Dr. Bilal Hamid. This is an agenda of today's webinar. After introductory remarks by Dr. Reddy, we will embark on a debrief of the Clinical Insights document posted on the AASLD website. Again, with Dr. Fix and Dr. Hamid, we will follow that with a question and answer session and then summarize today's webinar. So first, a rationale for why AASLD put together this Clinical Insights document. In regards to the COVID-19 pandemic, there is clear-cut potential for direct infection of the SARS-CoV-2 virus of the liver itself. Elevated AST and ALTs are frequently seen in patients, particularly with severe disease. The complications of ARDS and the cytokine release syndrome are prone to infect or affect the liver. The therapies that are being introduced for COVID-19 have unique hepatotoxicities. And there are, of course, unique potential susceptibilities in chronic liver disease, post-transplant patients, patients with autoimmune hepatitis on immunosuppressive agents, as well as risks for transplantation itself during the COVID-19 pandemic. So as a result, we felt strongly that there was a need for guidance for providers of care to patients with liver disease and those with the conditions listed here. So we assembled a working group listed here, members of whom are also available on this webinar to assist us with questions and answers. So without further ado, I want to introduce Dr. Raj Reddy, who will moderate the remainder of the program.
Thank you, Ray. Welcome, everybody. These are indeed rather challenging times for all of us dealing with this infection. So as a background, we now have recognized that SARS-CoV-2 is the virus, and COVID-19 stands for coronavirus disease 19, 19 representing 2019. This is a novel enveloped RNA beta coronavirus that was first identified in Wuhan, China. It has similarities to SARS-CoV. It predominantly causes an infectious respiratory disease, and it's problematic in older individuals and those with underlying comorbidities. So if you were to trace the history, back in December 2019, there was a cluster of pneumonia cases. Next slide, please. In China, and then this was subsequently identified as a novel coronavirus. Then there was a fatality reported in January 2019, and then, well, the first case in the US was in January 2020. Prior to that, there was a case in Thailand, outside of China, and then now we are really dealing with a pandemic. While Ray is trying to advance the slides, talk a little bit about symptoms and clinical presentation. Again, this experience comes from Wuhan, China. In an early study of 138 hospitalized patients, fever, fatigue, and dry cough were the most common symptoms. About 30% had dyspnea, and then some had diarrhea. And then if you were to look at the seriousness of the illness, about 81% were categorized as mild, about 14% were severe with a variety of pulmonary manifestations, and then about 4.7% of cases were categorized as critical, and this comes from the Chinese Center for Disease Control and Prevention. The incubation period has been determined to be up to 14 days, with an average of 4 to 5 days. Now, this is quite an alarming map. This is a U.S. map, which shows an approximate number of cases in various parts of the country. The size of the bubble indicates that indicates the density of cases in a given area. As you can see now, the epicenter is New York. There have been 30,000 plus cases in New York State, over half of them being in New York City. In the United States, there were 60,000 cases and over 800 deaths. Worldwide, though, there have been over 20,000 deaths with close to 500,000 cases worldwide. And as of 2 days ago, there have been about 10,000 new cases per day reported in the U.S. So quite alarming statistics with a rapidly evolving and growing number of cases in the U.S. with high mortality. Next. Well, if you were to look at populations at risk, again, this is based on experience in China. There are a fair number of patients with comorbid conditions who had confirmed cases. If you were to look at hypertension, diabetes, cardiovascular disease, they dominate as comorbid conditions, followed by chronic respiratory disease and those with cancer. Of course, there are a sizable number of individuals who had no comorbid conditions, while there's data missing in over 23,000 individuals. If you look at case fatality rate, it was the highest in those with cardiovascular disease. And if you were to look at fatality rate by age, there was about an 8% fatality rate in those between the ages of 70 and 79, and about 15% fatality rate in those greater or equal to 80 years of age. Now, the CDC has identified individuals at higher risk for severe illness, and these include individuals aged 65 years or older, those living in nursing home or long-term care facility, and those with a variety of comorbid conditions such as chronic lung disease, moderate severe asthma, heart condition, those who are immunocompromised, including those on cancer treatment, morbid obesity, and diabetes and renal failure. And quite relevant to us are those with liver disease who might be at increased risk for severe illness. So with that background, our society endeavored to develop some recommendations in taking care of patients with a spectrum of liver diseases. And to provide you all an overview of the various aspects of liver diseases, we have Dr. Oren Fix and Dr. Bilal Hamid. So with that, I'd like to pass this on to Oren to provide some clinical insights.
Thank you very much, Raj. And thanks everybody for joining. This is quite an impressive attendance and we appreciate it. I'm going to be covering the first half of our document, and then we'll pass it off to Dr. Hamid to cover the second half. So these are the topics that I'll be discussing. Next slide, please. So starting with the effects of SARS-CoV-2 on the liver and evaluation of COVID-19 patients on evaluation of liver biochemistries. What we know is that SARS-CoV-2 binds to ACE2 receptors to gain entry into cells. And in addition to pulmonary epithelial cells, which is the predominant problem. We also find ACE2 receptors on liver and biliary epithelial cells. So we know that SARS-CoV-2 has the potential to directly infect the liver. We see, as was mentioned in the introduction, a pretty high proportion of elevated liver tests in hospitalized patients with COVID-19. Some studies showing a range anywhere from 14 to 53%. And it's predominantly AST and ALT elevations more than bilirubin. The elevations tend to be mild, maybe 1 to 2 times normal in the beginning, but then seem to progress as the severity of the disease progresses. So we have much more commonly seeing high liver enzymes in patients with severe COVID-19. In fact, there have been some rare cases of severe acute liver injury, very high AST and ALT in the thousands. We also noticed that severe COVID-19 is uncommon in children and is less likely to be associated with elevated liver tests in children. There are a lot of markers for disease severity. We hear about low leukocytes, lymphopenia predominantly, but also serum albumin seems to be a marker. Low serum albumin seems to be a marker for severity. Liver histology, there's not a lot of data on this, but from some of the studies looking at case series of patients who've had COVID-19 disease, biopsies show anywhere from moderate microvesicular steatosis and mild lobular portal activity, all the way to focal necrosis. But really, there's not a lot of data here, and we really don't know whether this is from direct viral infection of hepatocytes or whether it's from other causes. Next slide, please. So what we don't know is whether the elevated liver tests in COVID-19 are from a direct viral effect, or are they secondary to inflammatory or immune response from the disease, or are they from drug hepatotoxicity? We know again that the virus can directly infect hepatocytes, and when we look at data from MERS and SARS, particularly SARS, we know that liver biopsies and autopsies showed evidence of direct viral infection of hepatocytes. We don't know if patients with chronic liver disease, such as hepatitis B, hepatitis C, and fatty liver, are more susceptible to liver injury from SARS-CoV-2, as we saw in SARS. And we don't know if SARS-CoV-2 can exacerbate cholestasis in patients with PBC or PSC. And I'll also add that we're also seeing a lot of severely ill patients who have very high AST, high LDH, high CPK, and we don't know if the liver enzyme abnormalities are due to potentially myositis or cardiogenic shock and not directly from liver injury per se. So based on what we know, we recommend the following. Test for hepatitis B and C in patients with COVID-19 and elevated liver tests. Avoid unnecessary imaging unless there is a clinical suspicion for biliary obstruction or cholangitis. As hepatologists, we have a knee-jerk reaction to get an ultrasound in every patient that walks through the door, particularly if they have abnormal liver tests. But in this day and age, we really need to be careful. We don't want to send patients unnecessarily from home to get an ultrasound or transport patients throughout the hospital if it can be avoided at this time. Patients with COVID-19 and elevated liver tests should still be considered for investigational or off-label therapeutics. Again, abnormal liver tests are common in these patients. We don't want to exclude them from potentially life-saving therapies. Monitor liver tests in all COVID-19 patients, especially if they're treated with some of these investigational agents like remdesivir, tocilizumab, that we know might have some potential hepatotoxicities. Don't assume that patients with autoimmune hepatitis or rejection are flaring, or excuse me, don't assume that patients with autoimmune hepatitis or liver recipients are flaring or getting rejection when they have elevated liver tests. You need to investigate that. It may simply be from COVID-19 itself. And evaluate children with COVID-19 and elevated liver tests for underlying liver disease. Again, it's uncommon for children to have elevated liver enzymes in this disease. Don't assume that COVID-19 is the cause. Next slide. So moving on to stable outpatients and also patients with hepatocellular carcinoma. We know that asymptomatic patients can contribute to SARS-CoV-2 spread, and that includes both immunocompetent and immunosuppressed. We know that children are less likely to become ill, but can still be infectious and contribute to the spread. With regard to liver cancer, we don't know if these patients are at increased risk for severe COVID-19. We know from some case reports that cancer in general is a risk factor for severe disease, but those case reports do not include specifically liver cancer. Next slide, please. So our recommendations are to severely limit outpatient visits to urgent issues and clinically significant liver disease. For example, jaundice, ALT or AST over 500, or recent decompensation. Stagger patient arrival times and room patients immediately. Try to avoid patients congregating in a waiting room. Limit family and friends who accompany patients. In fact, I saw a patient recently who came with two of her sisters. I felt she needed to be seen in person. It was a patient with a new liver malignancy. And we unfortunately had to keep one of her sisters in the waiting room on a speakerphone while her other sister came to the exam room with the patient. Not ideal, but it's what we need to do now. As much as possible, use phone visits and telemedicine, and hopefully you know that CMS has relaxed a lot of the guidelines around telemedicine to allow us to do this amidst this pandemic. I won't go into details about that, but the AASLD has released some guidelines on telemedicine. Screen all patients for symptoms or fever or recent exposure before they come to the clinic space. Ideally, we're calling patients about 24 hours before their scheduled clinic visit and asking them about symptoms and fever and exposure. And if any patients have any suspicion for SARS-CoV-2, we are directing them to the hospital's process and policy for managing patients with a suspected infection. They should not be coming to our clinics for that. When patients arrive, you should again screen them for symptoms and fever, recent exposures, check each patient's temperature when they arrive. If possible, cohort patients with COVID-19 symptoms. So just like hospitals are trying to develop isolation units specifically for COVID-19 patients, and some hospital systems actually are able to designate an entire hospital for COVID-19. We should try to do this in our clinics as well. It may not be possible to designate an entire clinic space to just COVID-19 patients. It may not be necessary, but at least one exam room should be designated for that rare patient, hopefully rare patient who arrives with symptoms and needs to be isolated immediately. Don't evaluate patients with COVID-19 symptoms or fever in the hepatology or liver transplant clinic. Again, hopefully you're catching these patients before they come to clinic, but if they do show up with symptoms, you need to isolate them immediately. Don't bring them into your clinic if you know that they're symptomatic. And while some of these things might seem a little bit aggressive for some people out there, depending on where you are in the country or the world, I want to assure you that this is probably something you need to be thinking about right now and probably doing right now, even if it seems early in your part of the country or world. This is probably coming to you if it isn't already there, and you need to have policies to limit exposure of patients and healthcare workers to each other and avoid having patients come into the clinic as much as possible starting now. Recommendations regarding liver cancer specifically: consider reviewing images of new referrals for liver masses and tumor board or with expert radiologists, depending on your center, before scheduling an in-person visit. In some cases, you might be able to triage this patient who potentially could wait if it's likely to be a benign lesion, or maybe they're better served in another clinic like an oncologist or an interventional radiology clinic rather than coming into the hepatology clinic. Continue usual surveillance imaging in patients with cirrhosis, hepatitis B, or liver cancer. This has been a contentious issue because in a lot of cases, centers are considering these surveillance imaging studies to be elective and could be postponed. And in some cases that might be reasonable. An arbitrary delay of 2 months is probably reasonable in most patients and might be necessary in your center. But in general, consider that this pandemic is not going to be going away in 3 months. And a lot of these patients who are due now or very soon for their routine imaging probably can't wait until this is over. And then finally, proceed with HCC treatments. These are not elective procedures and we should continue to provide them. Next topic is patients with decompensated cirrhosis, liver transplant evaluations, and those on the transplant waiting list. So we know now that nearly all OPOs are testing for SARS-CoV-2 RNA, but this is probably going to be variable depending on where you are. Test performance is not perfect. For example, sensitivity of nasal swabs is about 63%, pharyngeal swabs 32%, BAL is the most sensitive, 93%, and the more sites that you test, the higher the sensitivity. But the capacity for testing is limited depending on where you are. The turnaround time is going to be different depending on how far away the test has to go and the type of test being used. This is really a moving target. Rapid tests are being developed, including antibody tests, and please keep an eye on this space because it's going to change. It's going to change how we practice, who we test, and how we interpret those tests. What you really need to do is focus mainly on symptoms, even when you have a test available. In a patient that has symptoms or fever, even if the test is negative, considering the low sensitivity for some of these tests, you need to strongly consider that that patient may be infected. What we don't know are the effects of SARS-CoV-2 in patients with chronic liver disease, decompensated cirrhosis, or those who are awaiting liver transplantation. So our recommendations, again, like the outpatients, the stable outpatients, you need to limit the number of patients coming to clinic for liver transplant evaluations. Really think about how you're going to triage these patients, whether it's by MELD score or some other indication of how likely the patient is to be listed and transplanted very soon. Try to use telemedicine and telephone visits as much as possible, not just for clinic visits, but also for those things that don't require an inpatient exam, like patient education, social work, dietitian, and financial consults. And also try to limit your staff and providers traveling around for outreach clinics, and try to use telemedicine for those clinics as much as you can. If you're going to have in-person patient education, try to avoid multiple patients in one room. Practice good social distancing in that case. And when you're obtaining labs, do not obtain labs or imaging unless it's clinically necessary. In particular, hopefully many of you are aware of the new OPTN policy changes. We no longer need to get lab updates along the usual schedule, 1 week, 1 month, 3 months, depending on the MELD score, just to keep the patient's MELD updated. If a patient misses their usual lab schedule, you can copy forward the last labs and they can maintain their MELD without losing their place on the waiting list. Don't send patients to get labs only to update their MELD score. It's not necessary right now. Ensure patients have adequate supplies of medications, prescribe 90-day supplies instead of 30-day supplies. Instruct patients to avoid community recovery support meetings such as AA. Many programs require these types of meetings to be listed or to remain on the list. We really should not be requiring this of our patients or even encouraging this of our patients right now. In fact, a lot of AA meetings are being canceled appropriately. But provide telephone and online resources as much as you can so patients can continue to get the support they need. And for patients who are decompensated, who are listed for transplant, instruct them not to travel during this pandemic. Finally, liver transplantation, resource utilization, and ethical considerations. So the first thing I'll say when it comes to resource utilization and ethical considerations in this community, we've got this. We're used to dealing with this. We know what it's like to have to ration care for those who most need it, to deal with scarce resources. Obviously, COVID-19 is making this much more difficult for us. This is a new territory for us as well as most other providers. But we can understand what it's like to ration care when necessary for those who need it the most. But when you're considering transplant in this scenario, really consider that transplant is not an elective procedure. And unfortunately, CMS has clarified this in their document about elective procedures, that transplant is considered tier 3B, meaning it should not be postponed. And then finally, people who test positive for SARS-CoV-2 are medically ineligible for organ donation. We really just don't know the risk of transmission, and we really should not be transplanting these organs if we can avoid it right now. What we don't know, and I admit these are very philosophical, theoretical questions without real answers, but we don't know which life is more valuable and in need of a limited resource. Is it the COVID-19 patient, or is it the patient with an urgent need for liver transplantation? This is a big problem in a lot of centers where administrators, rightfully so, are focused on COVID-19, the anticipated surge, the concern about lack of ICU beds and ventilators and blood and PPE. They're not focused on transplant. But we need to be advocates for our patients and our programs, because some of our patients can't wait. And some of our patients are as much in need of those resources as a COVID-19 patient, especially a COVID-19 patient in the future. So it's not reasonable, for example, to halt all transplants or to ration transplants to the point where a patient with a MELD of 38 and refractory ascites is not getting transplanted because of the future anticipated need for that bed or that ventilator for a COVID-19 patient. Also consider whether it's ethical to start a patient on immunosuppression now. This has been an argument put forward that maybe we should not be taking a patient who's not immunosuppressed and put them through transplant and potentially put them at higher risk for infection or severe disease. But actually, we don't know if immunosuppressed patients are at higher risk of severe COVID-19. If you look at data from SARS and MERS, post-transplant patients did not do worse in those epidemics compared to non-immunosuppressed patients. It may actually be that the immunosuppression is protective from the cytokine storm and the severe immune response that we know leads to ARDS and death in these patients. And finally, will we need to ration transplants? And if we do, how do we prioritize? It may come to a point throughout this country, and certainly in some areas like Seattle, New York, California, where we're going to have to make some very difficult decisions like we've seen in Italy. And when we do that, we need to really think about how we're going to make those decisions. Is it going to be based on MELD score? Is it going to be based on likelihood of survival after transplant, things like that? But at some point, we may not have a choice. Our administrators will tell us, you don't have an ICU, or you don't have an OR because the OR is now an ICU, or you don't have a ventilator, you don't have blood. And we may not have much of an option when it comes to that. And so we need to start thinking about how we're going to ration transplants now if necessary. So our recommendations, these are difficult, challenging issues with no right answers, but start thinking about them now, because you're likely going to have to come up with some decisions and policies in your program eventually if you're not already thinking about it. Make sure your administrators are aware of the CMS Tier 3B designation. Again, that transplants are not elective procedures. They should not be postponed. Having something official from CMS actually goes a long way in those discussions. Consider your resource utilization in the decision to proceed with liver transplantation, whether you're getting this information on a daily basis or whether you just get it as soon as you have an organ offer and an appropriate recipient. You need to find out if you've got enough ICU beds, ventilators, PPE, and blood to proceed, or you might have to say, we can't do this right now. And be aware that COVID-19 prevalence and the resources available to manage it are going to vary across the country, and they're going to vary as this pandemic progresses. So we can't provide blanket recommendations for every program. This is really going to have to be developed within your local program. So last slide for me, recommendations also are to screen potential donors for exposure and COVID-19 symptoms and fever, again, regardless of test results or test availability, because the test results are not perfect. And also screen recipients for COVID-19 symptoms, fever, and exposure before you call them in from home for transplant. We should not be transplanting patients with a high suspicion of COVID-19. Consider testing asymptomatic recipients and donors for SARS-CoV-2 before transplant if available. I recognize this is a controversial recommendation because a lot of hospitals are not allowing asymptomatic patients and caregivers to be tested. Hopefully with more widespread testing, with more reliable testing, this will be less controversial. But I think transplant is a different animal, and we really should be considering testing all these patients if we can, because even if they don't have symptoms, we might be able to pick up some patients who are positive before we proceed with transplant. Think about suspending living donor liver transplant programs. This is not a blanket wide recommendation. There are certainly some living donor transplants that should not wait, but for the most part, living donor transplants could probably wait a couple of months. Exceptions might be pediatric patients with acute liver failure. And in all of these very difficult decisions, try to consult your local medical ethics committees for help. Of course, just putting in a plug, all of these recommendations are in our COVID-19 Clinical Insights document on the AASLD website. We plan to update this as often and as necessary as we get more data. So please keep an eye on that. And with that, I'll turn over the talk to Dr. Hamid.
Thank you, Oren. It's an honor to present on behalf of AASLD COVID-19 Working Group. Next slide. So part of my talk will be focused on post-liver transplantation, management of patient on immunosuppressive agent, patients who are on an inpatient service, medication management of patients with COVID-19, and procedure mainly specific to our liver patients. Post-transplant patients. So clinical outcomes of transplant recipient with COVID-19 are not known. However, what we know are post-transplant recipients who are older than 60 years of age and immunosuppressed are more likely to acquire SARS-CoV-2 infection. It is too early to know if immunosuppressed patients are at greater risk for severe COVID-19. The data from SARS and MERS epidemic showed that immunosuppression was not increased risk factor for mortality, but these patients had higher viral load. Immunosuppression may prolong the viral shedding. Our recommendation is emphasize preventive measure for our transplant recipient and patient. Although most of our patients follow this, but it is very important to reinforce this. Frequent hand washing, social distancing, cleaning frequently touched surfaces, and staying away from ill contacts. There are programs who are actually sending letters to the recipient and talking about it, and I think it's a very good idea. Again, as Oren has mentioned, minimize in-person visit for our post-transplant patients and maximize the use of telemedicine. Advise against any travel at this time of pandemic. Also important is to advocate for our patients they can do work from home or excuse from work, not only for themselves, for primary caregiver. In San Francisco, we do have a shelter, but before that, there are patients which I had to write an excuse. So we have a lot of questions, and this is about the management of immunosuppressive agent. So what we know, the effect of immunosuppression on COVID-19 at this time is not well established. However, reducing or stopping immunosuppressant can have their own consequences. You can have a flare-up of autoimmune hepatitis, or you can precipitate acute rejection. At this time, WHO recommends avoiding corticosteroids for COVID-19 unless it is indicated for another therapeutic purpose, like treating COPD or asthma. So recommendations in patients who without COVID-19 is not to routinely reduce immunosuppression. However, if we have a patient with COVID-19, consider minimizing the dosage of high-dose prednisone if they're on for autoimmune hepatitis or rejection or recent transplant, but maintain a dosage to avoid adrenal insufficiency. Consider reducing, but not stopping, the immunosuppression calcineurin inhibitor, mycophenolate, azathioprine, especially in the setting of lymphopenia, fever, or pneumonia, which we attribute to COVID-19. Now, it's important to be cautious in initiating prednisone or immunosuppressive therapy, where the potential benefit might be outweighed by the risk. And the example is alcoholic hepatitis. Recently, I had a patient on our consult service with alcoholic hepatitis. We did not want to start prednisone, and the next day, patient had symptoms and is now undergoing exclusion for COVID-19. What about the inpatients? So healthcare workers are at risk of COVID-19. Data from Italy and other countries that 20% of healthcare workers had COVID-19. So minimizing interactions among healthcare workers and also between patients and healthcare workers is very, very critical to reduce the spread of SARS-CoV-2. Minimizing the transport of patients within facilities going to radiology could reduce the spread of SARS-CoV-2. So recommendation is doing rounds with minimum number of personnel and only few team members entering the patient's room. At our institution, we have implemented virtual rounds and only attending and one team member who's taking care of patient are entering the room. The goal is to minimize exposure to the patient. Disband any in-person multidisciplinary round. These all can be done virtually. Also, consider restricting the direct patient care of our providers who are at higher risk, and providers who are older than 70 years of age, who have serious medical conditions or immunocompromised. We need to protect them, and so we need to have rules about it. We have to carefully consider all requests for labs, imaging, and procedure. And this is, beside COVID-19, this is a good practice. Patient visitors must be limited. There are hospitals like ourselves who has no visitor policy at this time. But if your program or hospital did not have a policy, it's very important for a transplant and liver patient that we should have some limitation of the visitors. Other important point is if you need an interpreter, use a telephone or virtual translation, again, to reduce any contact with patients. Now, we need to have a policies for reviewing and triage of hospital inpatient transfers. And it can vary from hospital to hospital and how much patients for COVID-19 are you seeing. But our institution, the only patient we are transferring if they have acute liver failure, they have a MELT of greater than 30, or they're coming for transplant. and post-transplant patient if they have rejection or some biliary complication. So it is important for programs to have a triage and hospital inpatient transfer policy. Avoid any direct admissions for patients with fever or respiratory symptoms. We need to rule these patients out for COVID-19. These patients need to go to appropriate places, because last thing we wanted to do is to bring these patients on our transplant floor. We need to have COVID-19 in the differential diagnosis of someone with a new onset hepatic encephalopathy. Recently, there's a case report which I'm reviewing for a submission with a patient coming with new onset hepatic encephalopathy and had COVID-19. Now, we have patients with underlying liver-related pulmonary diseases like hydrothorax, portopulmonary hypertension, and hepatopulmonary syndrome. If these patients have COVID-19, we need to be very aggressive in their airway management. Next slide. So medical management of COVID-19. All of us are aware that there are no approved medication for COVID-19. There are a lot of investigational and experimental therapies that has been now in different phases. Remdesivir and IL-6 receptor blocker tocilizumab are in randomized controlled trial. I just wanted to mention that both of these, the ALT and AST of greater than 5 times the upper limit of normal is an exclusion for clinical trial. Remdesivir is also being used as a compassionate use. Hydroxychloroquine and azithromycin there's a lot of talk about it. There was a recent study which was published from France, had about 30 patients, which was open label. And only thing it shows that the patients who were on hydroxychloroquine and azithromycin had a decreased viral load. There was no clinical outcome, so we need to await for a bigger study. It is important that all these medications, there's a big concern for drug-drug interaction. There is also concern for safety, like cardiac arrhythmias. Hydroxychloroquine and azithromycin combination have caused prolonged QT prolongation. And I will also talk about the lopinavir and ritonavir. Next slide. So there is a randomized controlled trial which was published in New England Medical Journal of lopinavir and ritonavir of 200 patients with severe COVID-19, which unfortunately did not show any clinical benefit. There was no mortality benefit, and even there was no change in the viral load. So this medication, lopinavir and ritonavir, are potent inhibitor of cytochrome P450 system. I have seen several institutions protocols still have them as one of the medications. So if someone is using this medication, we need to be very focusing on drug-drug interaction with our immunosuppressive agent. European Society of Cardiology recommends continuation of usual antihypertensive therapy, including ACE inhibitors or angiotensin receptor blockers. So our recommendation is, based on the evidence, we do not support the use of lopinavir and ritonavir for patients with COVID-19. Patients who are on chronic ACE inhibitors or ARBs should remain on them even in the setting of COVID-19. Acetaminophen less than 2 grams per day is a preferred analgesic. If some of your patients are in a clinical trial or compassionate use with remdesivir or tocilizumab, it is very, very important that we need to monitor their liver chemistries. And if their liver chemistries are going up, we should use either investigator brochure or FDA guideline for stopping these medications. Next slide. I like this website some of you has used for hepatitis C. It's a Liverpool drug interaction group who came up with interaction with experimental COVID-19 therapy. And they have different classes of drug, but this is for immunosuppressant. So again, the point is, if your patient with COVID-19 or you've been called upon for a consult, if they're using any of these medications, please talk to your pharmacy and look for interaction and adjust your immunosuppression based on that. Lastly, about the procedures in our patient with liver. So what we know is endoscopic procedure should be considered aerosol generating. There is a potential for fecal oral SARS-CoV-2 transmission, and also virus is detected in saliva. The Joint GI Societies recommend to strongly consider rescheduling non-urgent endoscopic procedure. So by looking at all the data and what we have available, our recommendation was to cancel all elective and non-urgent procedure. And this is not only for endoscopy, but for liver biopsies and fibroscan. I know we has a lot of questions about fibroscan, but fibroscan are not urgent and we recommend not to do fibroscan at this time. But there are certain procedures that can be performed based on their urgency. I just did a liver biopsy this morning to rule out rejection. There is a new patient for autoimmune hepatitis diagnosis. Therapeutic paracentesis, patients do need that. But it's important if these patients are coming to your clinic, you need to get a history of COVID-19 symptoms. So you don't want them to come in with cough to pay attention. Tips for acute variceal bleed, endoscopy for bleeding or variceal bleeding, or if someone has a high-risk stigmata recently and you need to get band ligation for secondary prophylaxis, those should still be continued to do. And biliary complications like cholangitis, or in our post-transplant patient, if they need an IR procedure or they need a half biliary obstruction, those are procedures still be urgent and need to be done. Our focus, there are a lot of good guidelines about use of appropriate personal protective equipment. I would like you to go some of these recent studies to go over. Other important point is consider limiting the involvement of fellows in endoscopy. Again, less interaction, less chance of exposure, and we can also in demand of personal protective equipment, so we can also have that would be also important in that regard. Again, as Dr. Fix has mentioned, please go over our for further detail about our document. And this is the end of my presentation. Thank you.
Oren and Bilal, thanks very much. And now we will open this up for questions and have a discussion. So there are quite a few questions here, and the first one would be for Oren. Oren, there will be quite a few questions around AST, ALT elevation. Is this virus causing a severe hepatitic illness? Do the height of transaminases correlate with prognosis? Does albumin level give us a sense of a prognosis? Where do we stand? Is there are there any cases of severe acute liver injury directly related to the virus or acute liver failure, or it's just more a phenomenon of a systemic process? What are your thoughts?
I think it's really unknown right now. First of all, there are no known cases of acute liver failure related to COVID-19, but there are probably acute liver injury, particularly very high AST and ALT in the thousands. But we really don't know. This is currently associations, and we don't know which came first, whether the liver injury is driving the disease, but it's more likely the other way around, that we're seeing sort of a bystander effect of the severe inflammatory disease and shock causing liver abnormalities. We do know, again, that the virus can directly infect the liver, so there probably is some viral hepatitis in liver happening. We saw that again in SARS, so that's probably happening, but I don't think it's the predominant issue when we see abnormal liver enzymes. Albumin is, again, associated with severe disease, but there's so many factors that go into that. It's hard to know if the albumin itself is a marker of future severity or whether that just comes along as the disease progresses. I think it's really unknown right now, but what we do know is that as the disease progresses, we're seeing higher liver enzymes in general and lower albumin.
Right. Great. Thanks. Now I'd like to direct a question at Mike Shilsky. Mike, you've been active in responding to questions about corticosteroids, azathioprine, and mycophenolate in the non-transplant recipients in autoimmune hepatitis. What's your take? What should we do? And the other question that's come up is that, in the document we've said it should maintain at least 10 milligrams of prednisone. There's a question raised, well, this infection may induce an inflammatory cytokine storm. Should it be 20 milligrams rather than 10 milligrams? What are your thoughts, Mike?
Thank you, Raj. I think we have to differentiate from the very sick COVID patient with severe disease who people may be trying to treat with high-dose steroids for different reasons. But for our chronically maintained patients with autoimmune hepatitis, we probably shouldn't make adjustments. For those who are in the throes of either a flare of disease or who are initiated on treatment recently on higher doses, the aim was to suggest that the dose be lowered to a point where their disease is still controlled, but that they do not become adrenally insufficient and at the same time are not at higher risk for prolonged or more severe injury. Viral shedding may be increased as well when the immunosuppression is higher, the length of time. So I think we really want to be a little bit more minimalist, but careful not to lower it too far and cause another flare of the disease as well.
That's great. Anyone else want to chime in, add anything to what Mike said? Great. So that's good. So, there's obviously a lot of concern about getting infected as a healthcare worker. Some of us deal a lot with immunocompromised individuals. Some of us are about the age of 65. I want to direct this question at Mark Russo. Hey, Mark, is there any value to walking around in a hospital with a surgical mask or N95? Where do we stand on it? And secondly, how do we kind of depopulate the healthcare workers in the sense that avoid congregation, you having just a minimum number of people on rounds, as to who should get into the room? If there are 2 or 3 people, should it just be one person, or can the entire team go in? Can you address those questions?
Yeah, thanks, Raj. To address the first question, I think part of the policy about wearing a mask is going to be, at least largely driven about the supply at the center. So just recently at our center, the policy has changed that if you're going on the hospital ward to wear a surgical mask and limit taking it off your face or touching it. So that surgical mask essentially will be worn the whole time that you're seeing patients on the inpatient rounds who are not persons under investigation or COVID positive. Of course, if you're seeing a person under investigation or a COVID positive patient, then you would wear the full PPE. As far as rounds, we have converted essentially almost everything to a Zoom or a Skype meeting for rounds. This includes our not only our physicians, but our ancillary staff like our pharmacists and social workers. And only one provider goes into a room with a patient. So we've really converted as much as we can realistically to video conferencing or conference calls and rounding one provider per patient room. Thank you.
All right, great. That's very helpful. So there are questions around immunosuppression in the transplant context. So this is an interesting question. So you had a liver transplant recipient and has a bout of, presumed rejection, and you prove it with a biopsy. David or Brendan, perhaps David, would your management of an acute cellular rejection in the current context be any different than what you normally do? Would you temper your immunosuppression in this context?
Well, I think that's a great question, and I think that a lot would depend on the timing of when the rejection occurred and what the tacrolimus level might be. I think that there's always a role to consider pushing the tacrolimus if you've got some room to do that early on if you're catching an acute rejection, and see if that might lower some of the inflammatory response without having to hit with steroids. We did that a lot in the era before we had hepatitis C effective treatments, and it works fairly well in a good number of patients. I think that based on everything that I've been reading, the experience of patients who have had rejection, and when centers both in Italy and in China have had to use steroids, they were able to successfully use the steroids without exacerbating the COVID or necessarily increasing the risk of COVID. I think the biggest thing to keep aware of is that when our immunosuppressed patients are infected already, that we do make them super shedders, and they will have higher viral replication, which means their risk to expose others goes up. And so I think we want to keep that in mind, especially if we're using steroids for rejection treatment. It would not be complicated to use them.
Great. Okay. So donor testing while you're on transplant, David. Donor testing. I mean, how are you doing it? What are you doing? I mean, do you do a questionnaire of the donors? Say someone is around 200 miles away. Are you asking for a CT scan of the chest to make sure that there are no pulmonary infiltrates? How are you addressing a offer for transplant?
Well, those are fantastic questions. I think that we're doing all of the above. It's been a moving evolution on what we've been able to do, going from questionnaires and only selectively testing patients who have had a history of upper respiratory tract infective type symptoms or fever, to testing every donor every time. It depends on what access different organ procurement organizations have to local labs where they can perform rapid testing. Right now, most OPOs in the United States are doing tests to every donor, and that we are seeing turnaround times that have been satisfactory in the majority of cases for identifying whether the PCR test is positive or not. In most donors, there are a few OPOs working out of a few hospitals where they haven't been able to find that answer out in time, and many of those donors, especially if it's an unknown reason or an unknown possibility that they could have symptoms of upper respiratory tract infection, or they've had a fever, they will abort the donor. They won't do it, or many organs won't be accepted. I think that most of the OPOs are hoping for the antibody test that's coming out, that's been FDA approved, waiting for reagent validation that can actually give a result in 8 to 10 minutes. That is on the horizon, hopefully imminently, but we do have a test that has already been FDA approved coming from Northern California that has been distributed widely across the country, that has a 45-minute window for on-site validation. And that test, I hope, will be coming into play, and that way every donor can be tested every time, and hopefully similarly every recipient, when they're being admitted for transplant or prior to transplant, we'll be able to run a test on the recipient prior to transplant as well, and be tracking that data.
Right. Brendan, questions around care of post-transplant patients. Are you doing anything different apart from telemedicine in terms of decreasing the frequency of monitoring their hepatic function, renal function? Are you dropping immunosuppression? And if you are, in what situations? Can you just give a bit of an overview of how you're handling your liver transplant recipients?
With our patients in Alabama, if they are over a year out, for the most part, they're stable, and probably very little needs to be done regarding those patients. The patients you're probably most concerned are the ones that are being discharged from the hospital for various reasons. And sometimes you may need to see them or do a telephone visit with them. The other group is the ones that are just freshly transplanted. We have started video conferencing clinic visits for them. The biggest issue is really the pharmacy. The pharmacists are valuable in all this in terms of making sure patients understand what medications to take and how to take it. So video conferencing with the pharmacist is probably as valuable, if not more valuable, than probably our visits in clinic.
So, okay, great. Thanks. Anyone else wants to add anything to Brendan's comments? I want to ask Bilal a question. Bilal, you alluded to alcoholic hepatitis and the use of corticosteroids, and that we should exercise caution in the current environment. The question here, well, what if the patient is on corticosteroids and it's day 3 or 4, it is not reached the 7-day point where they've been assessed for response? And the second part is that, well, they've gone beyond 7 days and they've had a response by Lilly criteria. What do we do?
Yeah, I think it's a tough, it's individual case-by-case decision. Again, with any immunosuppression, the risk and benefit has to be, I would say, if the patient had a response and if it's day 3, and, I would talk to the patient and just explain, and I may continue it at that time. Again, there may be a disagreement even among our panelists, but that's what I would say reasonable. If they have a response, I would just have to be cautious and then just continue then. But I would love to hear from my own fellow panelists, because this is something we see.
Oh, this is Oren. I agree with you, and I think it really depends on whether the question is referring to a patient with COVID-19 disease or whether this is just a patient at risk. I certainly think if they're at risk and already responding to steroids, I probably would continue. If they have disease, you're going to have to assess based on how they're doing clinically in that setting.
Someone asked if we should use a 4-day cutoff for Lilly score. I'm not sure we have data to support that, but someone asked the question. Any response?
I think it's that has a role, Raj, and that would be one place where, if you're concerned to use that score, it's maybe not as well validated as a 7-day score, but this would be a good time to start considering it.
Good. So again, a question for Bilal. You addressed this, but perhaps you want to maybe again go over it in terms of use of ACE and ARB drugs. Do you have any specific recommendation? How do you feel about continuing the drugs? And none of the recommendation is not to stop them. Any further reiteration of what you stated?
Yeah, no, I think that's what we had a lot of patients with our hypertensive NASH patient who were on these medication, and then there were lot of talk about whether these medications can have some side effects, especially with COVID patient. But then a lot of societies, even European Society, came up with that, if patients are chronically on it and they have been well controlled, there is no reason to stop it. And but again, if we still need to have more data, like in any other condition with this is something new that we are dealing with, but recommendation is not to stop these medications right now.
Good. On a similar note, is it reasonable to suggest that we exercise caution in the use of the variety of drugs that are readily available to us, such as hydroxychloroquine and azithromycin because of adverse events. There are events such as prolongation of QT interval. They could be at risk for VFib, sudden cardiac death. What would you say, Bilal?
Yeah, no,
I know there's a lot of enthusiasm and of course passion to do something intuitively to help these patients, but don't you think we should be careful about really using these drugs off-label?
Yeah, absolutely. These are all off-label, and it needs to be like with the help of an experts and infectious disease colleagues to determine which to study, but we need more data. There is a study going on for post-exposure prophylaxis for hydroxychloroquine, but the most of the enthusiasm, the hydroxychloroquine, even for the first SARS epidemic, was studied at that time. With the recent French study, which shows there is a decrease in the viral load with 26 patients, but there was no clinical outcome. But we need to be very cautious with these agents, especially combining hydroxychloroquine to azithromycin, where they have seen more prolonged QT interval. There are certain institutions who have hydroxychloroquine as one of their investigation agent to be used. But again, based on what we know right now, we need to be cautious about using these agents.
All right. So that's important. If someone has, Ray, you may want to have a crack at this. If someone has a chronic B or chronic C, and they now have COVID infection, not necessarily severe, someone's asking, is it all right to start them on treatment, or can it be deferred? What would you say?
I think that the COVID stands front and center in terms of the management of that patient, particularly as someone who has early symptoms and you just don't know what direction they're headed. I think so. The idea of initiating antiviral therapy for C certainly is probably in question, and it should also be noted that, of course, the antivirals for Hep B and Hep C have no activity against COVID-19 or SARS-CoV-2 that we are aware of. From the vantage point of those who are already on therapies, however, particularly those who have been on treatments for just been recently started for treatment of Hep C, they should perhaps certainly continue those treatments moving forward, and it may very well be that there could be a hepatoprotective effect in that setting by reducing enzymes and potentially allowing them more cushion to receive more specific anti-COVID therapies that might be hepatotoxic. So for those who have not yet been treated, it's I think it may be again difficult to justify immediate therapy of Hep C or Hep B.
Right. That sounds very reasonable to kind of defer treatment, because COVID-19 certainly gains or has precedence over the other infections. Ray, there was a question on research, and both in an academic center and a community center. What should we do? I guess there are some that are very essential, life-saving drugs that fall under the umbrella of clinically essential trials, and then some are trials that involve NASH patients, or I guess not anymore hepatitis C. How would you handle them? What kind of advice would you provide the investigators out there?
Yes, and the FDA has weighed in on this as well. In essence, any observational research and interventional trials of non-life-saving nature should be paused. The only clinical trials that should be allowed to enroll are those that really have the potential to be life-saving or disease-altering, and for which you really don't know appropriate alternative treatments for the patient. Now, for those that are already in interventional trials, only those trial visits that are deemed essential to the conduct of the trial should be allowed, and all other study visits that are non-essential should be deferred. And I think this should be this recommendation, I think, should be observed for the foreseeable future until we see some ebbing of the pandemic.
That's wonderful. Well, we've had quite a nice, robust discussion, and I think I've answered most of the key questions. I really want to thank all the panelists, Oren and Bilal, for their participation. Incidentally, the panelists have been really active in answering the questions, so that's really very helpful, and thank you for doing it. So Ray, do you want to take it over and then kind of wind down the program?
Sure, and I again want to thank all of our panelists and presenters for their wonderful presentations. I do want to close with just a few housekeeping issues here, and one of them is really to again remind you that this is an absolutely rapidly moving area of development, both in terms of our understanding of what's happening epidemiologically, as well as advancements in treatments and diagnosis. So we urge you to follow the COVID-19, particularly as it relates to the liver, through our resources webpage on the AASLD website. On this slide, there is a link provided, and on the right, you can see what that link looks like in display format.
Can you move the slide, Ray? Can you move the slide to the next one?
Yeah, I did move. I think
okay,
the slide should be up. I'm sorry.
Okay.
And I also want to urge you to participate in continued conversation by joining the COVID-19 care community on AASLD's online community known as Engage. This is open to all members of AASLD, and to get there, you can log into the Engage portal using your AASLD username and password. Finally, I do want to point out that we are thirsty for knowledge and new information about COVID-19. Again, as it relates to the liver and generally. And the editors of Hepatology, Liver Transplantation, and Hepatology Communications, our core journals, are all accepting and fast-tracking review of COVID-19 original articles and case reports, and will promise expedited review of submissions. So we should see more in the coming weeks in terms of new information posted not just on the webpage, but through our journals as well. And please stay tuned to the website and to your emails for updates regarding additional webinars, as well as updates on the webpage related to potential registries for patients with liver disease. We will also likely be rolling out case reports and case conferences and discussions, as well as journal club formats to continue the conversation in real time with the liver provider community. So on behalf of Georgie Becerra, president of AASLD, as well as the entire organization, I want to thank you as providers for what you are doing for patients with liver disease out on the front lines, and we hope that you have found tonight's webinar helpful to you in that quest. Thank you again for your participation, and we look forward to continued contact and communication.